In this presentation, I'll be talking about MR imaging of spinal cord lesion. This presentation is actually naturally meant to follow the white matter diseases presentation. So if you haven't watched that one first, I recommend that you watch that one first and then watch this presentation. So lots of different lesions can occur in the spinal cord. These include inflammatory demyelinating lesions, infectious lesions that are vascular in nature, degenerative and spondylotic lesions, obviously a very common source of spinal cord lesions, traumatic, and also neoplastic lesions. The emphasis of this talk is going to be on sort of the non-neoplastic etiologies, and sort of the neoplasms I'll talk about towards the end, and I'll sort of lump them all, although spinal cord neoplasms could even have their own talk, but the emphasis will be on the inflammatory, infectious, vascular, all the other causes of spinal cord lesions. Whenever you're thinking about spinal cord lesions, it's important to think about the clinical presentation. As far as imaging goes, whether short segment or long segment, the degree of swelling, and whether the swelling is mass-like or non-mass-like. And as we'll see, it's not quite always evident. So a bit of terminology before we go ahead and get started that are very important. One is this concept of transverse myelitis. This is a syndrome that has a specific definition. It is not a diagnosis. It has a long list of differential that we'll get to in a little bit. Basically, the main things to remember about transverse myelitis, and the definition here comes directly from this New England Journal of Medicine article, is you have to have bilateral symptoms that localize to the spinal cord. They're not always going to be symmetric, but the symptom has to localize to both sides of the spinal cord. What this translates to for imaging, if you can see it on imaging, is you see lesion that involves both sides of the spinal cord. And then you need to somehow, there's some more clinical features, and you need to somehow demonstrate that there's inflammation in the spinal cord. This could be either through CSF sampling or by imaging demonstrating an enhancing cord lesion. Technically, for definition of transverse myelitis, you exclude compressive and neoplastic and vascular sources. Although, as far as I'm concerned, because on imaging, you don't necessarily know that. I mean, you don't know that it's not compressive. You don't know that it's not vascular. I include these in my differential diagnosis of transverse myelitis when I talk about it, just because by our imaging, we won't necessarily be able to exclude these all the time. And then the other concept is this acute partial transverse myelitis. It's again just a definition, just a syndrome. It's the same thing as transverse myelitis, except it's not bilateral. It's just one side of the spinal cord. And what it translates to on imaging is you have a lesion that only involves one side of the spinal cord and not both sides. Another imaging-only terminology that's good to know is the concept of longitudinally extensive spinal cord lesion. And what that means is they involve 3 or more vertebral body levels. So you can see this cord lesion right here involves 3 vertebral body levels, 1, 2, and 3. So this is a longitudinally extensive lesion. And these are very useful because they have their own differential, and they most notably will exclude some other causes of some other etiologies. Right, to get us started, we'll talk about an introductory case, and we'll think about this as we go along. This is a 34-year-old man with sudden onset focal unilateral spinal cord symptoms. Here's the spinal MRI. You have a T2 weighted image here, post-contrast the images here, and then T2 and post-contrast in the axial planes. So you can see a single lesion. Its lesion is unilateral, only involves one side of the spinal cord, and it's sort of anterior to the midline and involving the lateral aspect of the spinal cord. So now the question is, what is the most important next step of management? And this question is actually nice because it brings our white matter diseases lecture in the context of our spinal cord lesions lecture. So the options would be A, a lumbar puncture, B, IVA clear treatment, or C, brain MRI. And as you see, the correct answer would be C, brain MRI, as the best next step of management. Now, this is an aside, and it's a good segue to do a little bit of spinal cord anatomy. Assuming that this enhancing lesion is symptomatic, what is the most plausible symptoms that this patient is having? So first you got to decide which side of the body it is and what are the symptoms. Is it sort of burning sensation, meaning it affecting pain and temperature? Is it weakness, meaning it's affecting motor function? Or is it numbness, tingling, meaning it's a sort of fine touch proprioception? And the answer here in this particular case would be left hemibody burning. So let's talk a little bit about spinal cord anatomy, just because we had that segue. So the spinal cord is separated into the white matter that's in the periphery and a gray matter that's in the center. There's the anterior horn in the gray matter and the posterior horn. The anterior horn typically has most of the motor gray matter and motor sort of neurons, and then the dorsal horn has most of the sensory motor neurons. Now, as far as spinal cord symptoms go, a majority of the symptoms are caused by damages to the actual white matter tract, because these are the white matter tracts that are going up or going down. And if you have a lesion involving one of these white matter tracts, you affect everything that goes down. Versus if you affect something in the gray matter, and that involves only the sort of that particular level of the spinal cord is what's affected, because the remainder of the gray matter is normal. Versus if you damage all the white matters here, these white matters are going down all the way to the conus, and everything from that level down gets affected. So what are the most important of the white matter tracts in the spinal cord? So one is lateral corticospinal tract. This is the motor tract. So this would be located lateral aspect of the spinal cord, and it is posterior to the midline here. So you can see this is posterior to the midline. These fibers decussate or cross over in the medulla, so by the time they reach the spinal cord, they're actually on the right side, or the correct side of the body. So meaning that a left-sided cord lesion affecting the lateral corticospinal tract would result in weakness in the left side of the body. So if this lesion, as you can see, this particular lesion is lateral aspect of the cord, but it's anterior. If this lesion was posterior and was on the left side here, it would result in left-sided weakness. Then there's a dorsal column that's involved in fine touch and proprioception. And these also decussate in the medulla, and these are located in the midline and posterior. So if you had a lesion over here in the midline and posterior involving the dorsal columns, this would affect fine touch and proprioception on the same side of the body. So if you had a right-sided lesion that was posterior, it would affect proprioception, numbness, tingling in the right side of the body. And finally, is the lesion this particular patient has is the lateral spinothalamic tract. These are involved in pain and temperature sensation. These ascending fibers, I mean, these are sensory fibers, so they're ascending, they're coming from the extremity and going up to the brain. These actually decussate immediately in the spinal cord. So as soon as they reach the spinal cord, they cross over to the other side, meaning that these white matter tracts that are ascending actually carrying information from the opposite side of the body. So basically what that means is a right-sided spinal cord lesion, like here, that's affecting the spinal thalamic tract, impacts the other side of the body, so left side of the body. So this particular patient would be expected to have pain and temperature issues in their left side of their body, and that is exactly what they had. They had burning sensation. Why it was burning versus pain, unclear, but it was burning sensation on the left side of the body corresponding to this lesion. So this patient went on to get a brain MRI, as we alluded to in our first question, and here are the brain MRI images. You can see here there's a lesion involving the corpus callosum touching the lateral ventricle, and then here you can see a lesion in the posterior fossa, a sort of infertentorial lesion involving the cerebellum near the midline. Now the question is, does this patient meet the McDonald's 2017 diagnostic criteria for multiple sclerosis? And the answer is true. This patient now, regardless of what any lumbar puncture or any other studies show, meets McDonald's 2017 diagnostic criteria for MS, provided that a limited sort of mimic workup is excluded. So for instance, things like checking for Lyme disease and stuff like that, a lot of lab work basically. As you recall from our white matter disease lecture, the McDonald's criteria had imaging criteria, which were dissemination in time and space. Now, this patient, when you first had just the spinal cord MRI, you only had an enhancing spinal cord lesion. So spinal cord was one of the four regions as far as dissemination in space. So this patient did not meet dissemination in space based on just the spinal cord MRI. Then it was an enhancing lesion, but there was no non-enhancing lesion. So this patient also, based on just the spinal cord MRI, did not meet dissemination in time either. However, as soon as you got the brain MRI, you all of a sudden had a periventricular lesion. That was that lesion that was touching the lateral ventricle in the corpus callosum, and infertentorial lesion that was a cerebellar lesion. So all of a sudden, this patient now meets the dissemination in space criteria because you have 3 of the 4 spaces involved. Then those lesions that I showed you on the prior slide, they were actually all non-enhancing lesions. So now this patient has an enhancing cord lesion and non-enhancing brain lesions. So now, based on single time point MRI, this patient meets their dissemination in time requirement. So now the only thing is, does the patient meet diagnostic criteria for MS, meaning the clinical aspect? And the clinical aspect, I mean, we're not usually involved with, but this patient presented with new focal onset, focal neurologic deficits, so had an actual bona fide attack. So when you have an attack and you meet the imaging requirements for MS, you meet the diagnostic criteria for MS based on McDonald's criteria. And that's why it's important for these cases. So you have focal unilateral spinal cord lesions to proceed to and recommend brain MRI, because the brain MRI would allow you to basically diagnose MS. Doesn't matter what the lumbar puncture shows. If you get a lumbar puncture, no matter what it shows, you can't diagnose this patient with MS. And as I'll talk about briefly, with these cases of partial transverse myelitis, possibility of something like an infection being the etiology is extremely uncommon and sort of undetectable in series. So that's why it's important when you see these cases with focal cord lesions to recommend and get a brain MRI, because you can actually diagnose with somebody with MS without delay based on that single time point. So let's talk a little bit about acute partial transverse myelitis, and that's just basically cord lesion and symptoms that affect just one side of the body as opposed to being bilateral symptoms. When this uh, this is just a syndrome, obviously it's not a diagnosis, and the only reason it's useful is that people have categorized these and uh, looked at series of these patients and sort of categorized what their outcomes were at long-term follow-up. And as it turns out, the outcomes at long-term follow-up for partial transverse myelitis is 60% of the time they end up being diagnosed with MS. So again, very important in these cases that MS is at the top of your list as to what this could be. Another like 30% or so of the time, it's just going to be an isolated event and it's going to be idiopathic. So you can see just MS and idiopathic cases account for almost like over 90+% of the cases. And then there's things like post-infectious Sjogren, NMO, etc., that end up taking another 3% of the cases. Interestingly, in the series that I've read so far, I haven't seen any case of actual infectious, true infectious, active infectious myelitis presenting in this acute partial transverse myelitis syndrome. And remember that this syndrome, the acute partial transverse myelitis, has a clinical component. Clinically, the symptoms also need to be unilateral or correspond to a unilateral aspect of the cord. Sometimes, if the symptoms are bilateral to the cord, but you only see on cord imaging, like vague lesion in just one side of the cord, that doesn't count as partial transverse myelitis because clinically they have full transverse myelitis and you just happen to not see the entire aspect of the myelitis on imaging. So there is a clinical component to this. It's not just that you have a focal lesion, but when you have a nicely defined cord lesion like this and it's focal and unilateral, chances are clinically it's also going to be just unilateral symptoms. Now, when in this particular series, when they looked at risk factors to result in an ultimate diagnosis of multiple sclerosis versus all the other causes, they found that any brain abnormality as presentation, and that this doesn't mean things that meet McDonald's criteria, but any brain abnormality increase your odds ratio by about 8. And the brain MRI was normal in 74% of cases of idiopathic partial transverse myelitis, but it was only normal 13% of cases that end up having the diagnosis of MS. Unfortunately, that means that 13% of the cases you won't be able to diagnose them with MS at the get-go, but that's just the way it is. Now, another thing to note is that another risk factor they found for ultimate MS diagnosis was presence of oligoclonal bands in the CSF, and that had an odds ratio that was higher than any brain abnormality. But it's important to realize that these oligoclonal band, at least based on the current McDonald's criteria, they would never be enough to diagnose you, to actually give you the full diagnosis of multiple sclerosis. So even though it's better than any brain abnormality, if the brain abnormality you see at MRI actually satisfies McDonald's criteria, you have the diagnosis of MS, right? So it's important, I think, still first step after you see a lesion like this is brain MRI. If the MRI meets MS diagnostic criteria, you can forego lumbar puncture. And in fact, that case I showed you, the patient never got a lumbar puncture because, they had MS and it looked like MS, just had a very limited mimic laboratory workup. However, if the brain MRI was normal, or then it probably makes sense to look at the CSF. And if you see oligoclonal bands, that makes them a high risk sort of at developing multiple sclerosis. And you can sometimes even treat these patients as long as they're high risk. So let's talk about MS spinal cord lesions. So the McDonald's criteria defines spinal cord lesions as a lesion in the cord that's identified on at least two sequences or in two planes. So it can be either identified on your sagittal T2 and sagittal stir, or in two planes, like sagittal T2 and axial T2 or something like that. But it's important to realize that by McDonald's criteria, as far as diagnosis of MS, in order to be able to count a lesion as a true spinal cord lesion, you have to see it on two separate sequences. So these lesions, in particular, you can see it on two planes, the actual plane and the sagittal stir. Now, typically, but not necessarily for sure, these typically are going to be very short in their craniocaudal dimension, meaning they'll be less than 3 vertebral body segments in length. They'll be focal, usually affecting just one side of the cord, and they'll be less than 50% of the cord diameter. So in other words, these MS lesions are going to be rare for them to be longitudinally extensive. Now, as we'll see, sometimes in sort of aggressive and end-stage cases of MS, you have so many spinal cord lesions that they all sort of start to blend together and they mimic a longitudinally extensive lesion. But a lot of times, if you look closely, you'll see that the lesion, that what you perceive as a longitudinally extensive lesion, is actually a bunch of little lesions in different parts of the cord that sort of happen to just start to coalesce to each other because there's so many of them. I'm going to go through some example of MS spinal cord lesions. Here's a case of MS. You have these two lesions. You're clearly seeing them on the sagittal plane, and for each of them, you're also seeing them on the axial plane. They all meet sort of those criteria. They're short segment, they're peripheral, they're focal, and they involve less than 50% of the cord diameter. So they're pretty typical spinal cord lesions of MS in the cervical spine. Here are some example lesions, slightly more subtle in the thoracic spine. So here, these typically I tend to find first on the axial plane and then confirm that I see them on the sagittal plane. So here's some hyperintensity, involves the anterior cord right here at this level. And if you look at your sagittal plane, you have some hyperintensity at that same level anteriorly in the spinal cord as well. So this meets also those requirements for it to be in two different planes. Here's another lesion. You go through your axial, you can see this peripheral lesion right here, and then also you can see some hyperintensity seen on the sagittal plane right there. Very subtle, but when you see it so well in one plane, you can sort of have a slightly lower threshold for saying I see it in the sagittal plane. Here's another example lesion in the thoracic spine. This one sort of more ill-defined, sort of centrally within the cord, and you can see it again on two different planes, better seen on the sagittal in this particular case, but also seen on the axial plane. So here's another case of MS, spinal cord lesion, and this particular hyperintensity in the cord, you can see at first glance it looks like it's longitudinally extensive, and when you look at it and you scroll through this cord lesion, you can see it's sort of pretty patchy, almost as if it was a conglomeration of multiple different lesions. Again, it's hard to say at the first, if you see it at the first time, is it really a longitudinal extensive lesion versus a conglomerate of small peripheral lesions? And I think something like this will be very hard to say it's not a true longitudinal extensive lesion, but it's just to say that MS, especially when it's sort of end stage and long standing, can also sometimes even progress to that true longitudinal extensive cord hyperintensity that you can see in other things like NMO, for instance. But again, not very typical, especially when you only have a few lesions. So we'll talk a little bit about some red flags when it comes to spinal cord lesions and MS diagnosis. Obviously, first one is longitudinal extensive lesions. Anytime you see longitudinal extensive lesions, you got to think something other than MS. So I usually say it's a longitudinal extensive lesion. It's atypical for MS. This particular case was an NMO case, but other things could also be seen with longitudinal extensive lesions. Another red flag is the presence of leptomeningeal enhancement in the spine. It's very rare for MS to have leptomeningeal enhancement in the spine. It's a bit more common in the brain, particularly on postconscious flares, but in the spine, very uncommon. You see leptomeningeal enhancement, like you can see here. See here, this enhancement here in the anterior margin of the cord, and then you can see here all the way around the spinal cord, this enhancement, that's just all leptomeningeal enhancement in the cord. And that would be sort of pretty atypical for MS and should be considered as a red flag. Extensive posterior column involvement, sort of this goes a little bit hand in hand with longitudinally extensive, can also be a red flag for MS, particularly if it's symmetric on both sides. So like this case here, it's sort of symmetric and extensive posterior column involvement. This should make you think of things like vitamin B12 deficiency as opposed to MS.
Another one of these red flag type lesions is a syrinx. Now, syrinx typically is not a diagnostic dilemma, and what you need to know about it for imaging is that it's going to be CSF equivalent in signal. So, on all your different pulse sequences, it's going to follow CSF. So, you can look at your CSF here. On this stir, it's bright. This syrinx is going to be equally bright, and then on T1, it's dark, and this syrinx is equally dark. A lot of times, myelitis lesions they can be almost equally as bright as CSF on STIR and T2, but then on T1 they will actually not be equally as dark. So that's what distinguishes a syrinx from those other lesions. When the syrinx is very small and thin, it can be difficult. So you can somewhat, if you see something in the center of the spinal cord, you can somewhat hedge a little bit, but typically a syrinx is not going to be that much of a diagnostic dilemma.
Finally, another red flag to consider is the presence of this thing so-called pancake enhancement. What that means is there's a sort of enhancement at the periphery of the cord with some sparing of the central gray matter, as can be seen here, for instance, in this particular case. This is a very peculiar pattern of enhancement that's seen a lot in the setting of degenerative change and spondylitic signal changes in the cord. As you can see here, this particular person has a status post anterior instrumentation, and there's some narrowing of the spinal canal here, associated hyperintensity in the cord, and this pancake type of enhancement. When you see this pancake type of enhancement, especially when there's degenerative change at that level and spinal canal narrowing, you should think that this is not really an inflammatory process, but it's a process that's spondylitic due to the presence of degenerative change and cord compression.
So this is actually a good segue to talk a little bit about spondylitic or compressive myelopathy. Now, the most common form of this myelopathy that you'll see almost all the time in neuro is this, short segment due to hyperintensities at the site of severe stenosis, and they'll typically not be enhancing. So here's a simulated case of, you have some disc bulge, you have some ligamentum flavum thickening, the cord is compressed, and you have some somewhat ill-defined hyperintensity within the cord just at the site of the severe stenosis, and these typically will not enhance. So that's the most common situation with spondylitic myelopathy. Now, there is an important but kind of under-recognized by us radiologists enhancing pattern for spondylitic myelopathy that we absolutely have to be very much aware of. And that particular form is what I showed you on the slide before. That's going to be longitudinal, sort of extensive. The cord is going to look much more edematous. It's not going to be like this sort of almost narrowed cord. And then they'll have that pancake type enhancement pattern that I showed. And then in that particular pattern, you're going to have the hyperintensity extend from the site of stenosis, sort of inferiorly or caudally, typically.
So here's that case I showed earlier with the pancake enhancement in the setting of some stenosis up here, and you can see the hyperintensity being caudal to that level. This is that particular case after decompression, and as you can see, the hyperintensity is nicely gone away. The enhancement is almost completely gone away, so that hyperintensity is resolved as a result of decompression. So here's another case of spondylitic slash compressive myelopathy with enhancement. This one's actually much more atypical. You can see there's a lot of degenerative changes, some disc bulges, and probably superimposed central herniations that causing a lot of spinal canal narrowing. There's this very long segment, longitudinally extensive hyperintensity throughout the cord. It goes both upwards as well as downwards from the areas of stenosis. And as you recall, I said that typically with that enhancing pattern of compressive myelopathy, the cord abnormalities would be going downwards from the level of stenosis, but this particular case is going both directions. Here you can see the patchy areas of enhancement. Now the enhancement pattern is also pretty strange, and it's in fact the opposite of that pancake enhancement in the way that the central aspects of the cord and the gray matter of the cord is enhancing, while the white matter of the cord and on the periphery, well, probably a lot of the white matter is also enhancing, but the periphery of the cord is actually not enhancing. And the pancake pattern enhancement that's described in the literature is actually the exact opposite of this. So again, but the key here is whenever you have this degree of stenosis in your spine and you see uh, cord signal abnormality, even with enhancement, you should always keep this spondylitic etiology in the back of your mind and in your differential diagnosis. So here's that case, just a couple of days after posterior decompression, you can see marked improvement of the hyperintensity within the cord, complete resolution of the enhancement, confirming that the entire thing was a spondylitic compressive myelopathy. So this one's a more bizarre case, but in general, the moral of the story here is that you see a bad stenosis in your spine and some hyperintensity in the cord that's enhancing, think spondylitic or included in your differential. It might not always be right, but included in your differential, because if you include that in your differential, it might change what they do for the patients. And in particular, in this case, if you had said that things like a tumor or something, they wouldn't go and decompress the patient, for instance. They might want to try to biopsy the cord or something. But if you include compressive myelopathy and they do their decompression and it looks like there's nothing untoward, they might just not biopsy the cord and go ahead and just finish with their decompressive surgery. Now that we've talked about partial transverse myelitis as well as multiple sclerosis, we'll shift gears and talk about the transverse myelitis as well as the differential diagnosis of transverse myelitis mainly. So, differential diagnosis of transverse myelitis as a syndrome obviously is pretty broad. It has idiopathic, and that's usually around half the times. It's just idiopathic, usually happens once and typically doesn't recur. But then there's all these other etiologies that we should keep in mind and sort of look for. These include sort of autoimmune demyelinating like NMO and MOGAD, which we'll talk about. Systemic conditions, infections can cause transverse myelitis, paraneoplastic syndromes, vitamin deficiencies, as well as vascular and ischemic etiologies can result in a transverse myelitis appearance. I sort of italicized and put them a little bit separate because the definition of transverse myelitis sort of excludes these things, these vascular etiologies of cord problems. However, when you're looking at just imaging, you don't really know that it's vascular or not. So I included it here on the differential diagnosis of transverse myelitis simply because for us as imagers, we wouldn't know if sort of a longitudinal extensive lesion that involves both sides of the cord is not vascular just from the get-go. So we're going to include that in our differential as well. Now we'll talk about neuromyelitis optica. So neuromyelitis optica is one of the demyelinating conditions, and unlike MS, it's associated with an antibody against these ACU4 and 4 water channels. Its sort of average age of onset is about 40 years. Women are more commonly affected than men, and then it is also a relapsing and recurrent course, but the relapses tend to be more dramatic than MS. And now the classic neuromyelitis optica has a triad that's going to be a myelitis, and it's going to be a sort of your transverse myelitis pattern, a long segment, longitudinally extensive myelitis, optic neuritis, as well as the positive antibody. Here in this case of neuromyelitis optica, we can see some optic neuritis on the left with both enhancement as well as T2 hyperintensity of the nerve, best seen on these coronal fat saturated images. Now, neuromyelitis optica does have a consensus diagnostic criteria, and that's highlighted here in this neurology article. So if you ever in need of, want to review the diagnostic criteria, just search NMO consensus criteria 2015, and you can easily Google this. Now, it's pretty complex. There's a very complex interplay of clinical features and imaging findings. But as far as the imaging features that are considered characteristic of NMO based on that consensus statement, I've tried to outline here. So the first thing is optic neuritis, and in particular, what's considered characteristic for NMO is that the signal abnormality extends over 50% of the optic nerve or involves the optic chiasm. That's considered pretty characteristic, although probably any sort of optic neuritis requires an assessment for possibility of NMO. It's relatively easy enough to check for NMO anyways. And then as far as the myelitis go, it's considered characteristic where it's longitudinally extensive, meaning that the signal abnormality involves three spinal segments, three vertebral body levels. Alternatively, by the consensus criteria, focal cord atrophy, more than three vertebral body segments, is also considered to be characteristic imaging finding of NMO. As far as the brain findings, we talked about in the brain white matter diseases lecture, you have your area postremia as well as periependymoma hyperintensities, particularly in the brainstem, being pretty characteristic of NMO. But again, it's really a complex interplay of what clinical symptoms you have and needing a characteristic imaging findings. So it's not quite as simple as McDonald criteria for MS. And importantly, you need to have lack of MR features suggestive of MS. So if you see things in your imaging that are suggestive of MS, you should make a note of them so that people know that this last condition is not necessarily met. So now I'm going to show you guys some cases of NMO, in particular myelitis of NMO. So here's one case. You have a longitudinally extensive hyperintensity in the cord extending multiple vertebral body levels. And then on the axials, you can see it involves nearly entirety of the cord cross-sectional area. So this would probably fall into, clinically, would fall into the transverse myelitis pattern, and imaging-wise, it's a longitudinally extensive lesion. Here's that same case, again showing post-contrast images and pretty uniform pronounced enhancement. It's not always going to be this pronounced. It can also be pretty patchy and sort of very vague enhancement as well in neuromyelitis optica. Here's another case of neuromyelitis optica. You can see this hyperintensity. While it's most pronounced in these two vertebral body segments, it actually goes down further and extends beyond the three vertebral body segments. You can see here you have sort of enhancement of that area of the cord, and this one's a little bit more asymmetric, so it involves the right aspect of the cord more than the left, although still more than 50% of the cord cross section. Here, the enhancement, is not quite as uniform as that other case. Now, this is another case of a confirmed NMO, but I want to show this because this is a caveat case. This is sort of an atypical case. If you look at this particular case, you see that the hyperintensity in the cord is really very short segment. It's not longitudinal extensive at all. And if you go through the actual images, you can see sort of this is on a dorsal column, but it's just like very little. Then you have another lesion that looks like here, sort of periphery, and then some other lesions there. So it looks like very short, small lesions, kind of what you would expect in MS. The reason for that in this particular case is these are not active lesions. This is a patient that has NMO for a while, and these are sort of had prior episodes where they had longitudinal extensive hyperintensity and myelitis, and then this is over time that hyperintensity tends to start to resolve, and then you end up with these very patchy areas of signal abnormality that mimic MS. So again, in the chronic and phases where NMO is no longer active, the hyperintensity can start to disappear, and as it disappears, it can start to look quite patchy and look like a bunch of small lesions, like you would see in MS. That being said, if you have an active and acute sort of event, an acute episode of myelitis, NMO will pretty much almost always be longitudinally extensive. So in the late stages, and then once it's no longer active, sure, NMO can start to look like other things and non-specific hyperintensities of the cord. But in the acute phase, you really gotta have longitudinally extensive myelitis in order to be considered characteristic for NMO. Next, we'll talk about MOG antibody disease or MOGAD. This is another demyelinating condition. This is a disease initially thought along that NMO spectrum disorders, but this disease does not have a positive aquaporin 4 antibody, but instead has a positive antibody against MOG or myelin oligodendrocyte glycoprotein. Now, the clinical presentation of MOG tends to be sort of have some overlap with NMO in that optic neuritis is the most common initial clinical presentation in MOG, and it's one thing that's unique about MOG is that it's bilateral at presentation very frequently, so almost 50% of the time, depending on some series. It's the optic neuritis of MOGAD is thought to have a lot of disc swelling and or swelling in this condition is supposed to be more than other causes of optic neuritis, and anterior nerve involvement is considered to be more characteristic. Although in this particular case I'm showing here of confirmed MOGAD, you can see there's a lot of swelling, right? You can see this optic nerve much more swollen than this, but the involvement is really posterior nerve, and it's even extending to the chiasm. So again, I personally don't find distribution of optic nerve involvement to be very helpful because I've seen so many cases where sort of those supposedly classic rules get violated, but that's just something people say. And if you read about these in things like radiographics, you'll see these things mentioned, but I don't personally find them helpful. After optic neuritis, the most common presentation of MOGAD is actually myelitis, and then after that would be things like encephalitis and brainstem syndrome. Here's just an enumeration of the initial presentations you can see in MOGAD, and you can see that optic neuritis most common, followed by myelitis, and then after that, combination of optic neuritis and myelitis, and then everything else much more rare compared to those two phenotypes. So MOGAD, unlike NMO and MS, does not have a consensus diagnostic criteria. So, you just kind of read the literature and come up with a bunch of different findings people have described as being seen in the setting of MOGAD. So as far as the myelitis of MOGAD, it tends to be longitudinally extensive, anywhere from 60 to 90% of the cases. So it's not always going to be longitudinally extensive. So just because something's short segment, it doesn't mean it's not MOGAD. Some of the things that's been described in the setting of MOGAD is this central or H sign, where the central gray matter of the cord is hyperintense and the white matter is preserved, and it leads to a sort of this H-shaped appearance. I don't have any cases of confirmed MOGAD that have this, although I have other cases of other etiologies that really mimic this H sign, and I'll show you one later on. So I don't think it's specific for MOGAD to yeah. Then some other things that have been described in the setting of MOGAD is prominent of the central canal with enhancement. So, the central canal being very prominent and sort of, again, going with this central feature, sort of MOGAD. If you see something that's very central in the spinal cord, you can think of MOGAD, and especially if you see that the central canal is also prominent. And then conus medullaris involvement has also been described as being seen in the setting of MOGAD. So if you see any of these kind of particular patterns of distribution, you can include MOGAD in your differential diagnosis. So here's a case of MOGAD where the initial presentation was actually in the setting of syphilis, and you can see here this particular case is longitudinally extensive, involves three vertebral body levels as far as the cord hyperintensity goes. The enhancement is sort of more limited in its scope, and then on the axials you can see that it really involves a lot of the cross section of the cord. It doesn't really necessarily is central predominant. There is perhaps some prominence of the central canal in this T2 hyperintensity, but again, it's not particularly marked. So nothing really specific about this imaging appearance in my mind. It's sort of just a longitudinally extensive myelitis. Obviously warrants evaluation for NMO in this case also, but this particular patient had MOG antibodies. Here's the brain MRI from that same patient showing some of these white matter lesions with associated enhancement as well. So MOGAD can also have white matter involvement. The white matter involvements we sort of talk about in the white matter diseases lecture, but things like juxtacortical involvement as well as disappearing lesions tend to be characteristic, although here we only have a one-time point. More images of the brain in that patient showing some areas of leptomeningeo enhancement along the optic nerves. There was no optic neuritis per se, but there was leptomeningeo enhancement along the optic nerves and the chiasm, and then some more leptomeningeo enhancement you can see here. So you can see leptomeningeo enhancement in the setting of MOGAD. Here's another patient with MOGAD. This particular case, the myelitis, I don't think was active at the time. You can see this hyperintensity within the left aspect of the cord again. It's not longitudinally extensive, as you can see. It only involves about one vertebral body segment, and it's really not central. It's, if anything, it's eccentric to the left. So again, the distribution's not necessarily, I find that helpful, like those H sign, but if you see the H sign, if you see a central predominant cord hyperintensity, including MOGAD is probably a good idea. So shifting gears, I'm going to show an unknown case here. Here we have another longitudinally extensive case of myelitis with pretty pronounced symmetric involvement of the dorsal columns. Here's a brain MRI from that same patient showing very pronounced symmetric periventricular and confluent white matter hyperintensity, no diffusion restriction or enhancement. So when you see a case like that, the question is, what is the most important category of disease to include in the differential diagnosis? Is it A, demyelinating disease, or B, systemic inflammatory disease, C, a vascular etiology, or D, vitamin deficiency? And of course, the answer here is vitamin deficiency. So the case I showed you was one of subacute combined degeneration. It refers to degeneration of the dorsal, but also commonly the lateral white matter tracts of the spinal cord. So you'll have the dorsal column as well as the lateral corticospinal tracts being affected. It's typically going to be quite symmetric and a long segment. It's classically seen with vitamin B12 deficiency, but has also been reported with deficiencies of copper, vitamin E, or nitrous oxide abuse. The particular case I showed you was actually a genetic defect in vitamin B12 metabolism that resulted in that appearance, but again, the pathophysiology is the same. It's the vitamin B12 deficiency. That's a good segue to talk a little bit about differential diagnosis of dorsal column hyperintensity, especially when it's symmetric. The differential diagnosis also includes HIV-associated myelopathy, tabes dorsalis, or syphilis, although seeing syphilis bad enough to affect the spinal cord nowadays is very rare. Sarcoid can also result in dorsal column hyperintensity. Paraneoplastic syndromes can do that. And in fact, a term that's typically used for paraneoplastic syndromes is tract specific, meaning you see symmetric hyperintensities in the cord extending along the white matter tracts. And then also adult onset leukodystrophies can have a pretty pronounced symmetric dorsal column hyperintensity as sort of almost this like final common pathway sort of. So here's a case of sarcoidosis affecting the conus medullaris. You can see the hyperintensity really isn't quite dorsal only, pretty diffuse throughout the cord. But if you look at the pattern of enhancement, enhancement does involve the dorsal aspect of the cord, including the dorsal columns pretty prominently. This particular appearance, whether you have dorsal enhancement sort of along the periphery, but also extends centrally to the central canal, it's been thought to mimic a trident, and it's been called a trident sign. Some articles published on this and show it to be seen quite frequently in sarcoid. Don't I personally don't necessarily believe in it or think it's that helpful, but this is, you might read about it, and this is a case that I have that sort of look like that. It's sort of not really a multiple slice finding. Usually you can only see it that well in one slice. You can see this one slice looks pretty good, and then the slice after, it's okay. It's a bit asymmetric of a trident, and then on the next slice here, not really there at all. So again, something you might come across is trident sign, and if you do see it, if you see something that makes you think of a trident sign, just because people publish on it, probably good to include sarcoidosis in the differential, but I don't necessarily know if it's that specific for sarcoidosis. The articles I've seen of it is they always just say, "Oh, we had these cases of sarcoidosis and we saw trident sign in this high percentage of the cases." They don't necessarily have control groups of other inflammatory conditions to show it's got any specificity. Here's that case continued, the sarcoidosis case continued, showing some enhancement along the optic nerves. I think some of the enhancement is truly within the optic nerve parenchyma, but some of it is also probably leptomeningeal on the perineural sheath of the optic nerve, so perineuritis, which is pretty common in sarcoidosis as well. But I do believe in this case, some of it's got to be within the optic nerve parenchyma itself.
Another category of disease in the differential for posterior column hyperintensity are these adult onset genetic leukodystrophies or genetic white matter diseases. Now, this is a particular case of adult onset leukodystrophy. Here, there's very subtle cord hyperintensity in the posterior tracts, but there's also hyperintensity in the both lateral tracts, and there's a profound cord volume loss, as you can see here. This particular case was a genetically confirmed leukodystrophy. It's not the best case of posterior hyperintensity, but it's one case that I had. You can look at this radiopedia case for another case that shows a more pronounced posterior column hyperintensity. So keep these adult onset genetic leukodystrophies in mind, particularly if you see a lot of cord volume loss, and also if you were to see pretty substantial brain signal changes, because a lot of these adult onset genetic leukodystrophies can have very substantial brain signal changes, as we sort of briefly went over in the white matter diseases lecture as well.
So, shifting gears into other causes of transverse myelitis, obviously, always need the cases of transverse myelitis always require exclusion of infectious etiologies. Unlike the partial transverse myelitis, where true infectious causes are rare or not really measurable in the series, in transverse myelitis, infectious causes should always be excluded because that's what they would present with. So I have here a case of listeria or presumed listeria myelitis. In this particular case, you can see longitudinal extensive myelitis involving many vertebral body segments. There's involvement of the entirety of the cord. But here, this is actually a case that I thought that the central cord was more pronouncedly affected on the hyperintensity, almost mimicking the H sign. So you see, this is what the H sign would look like. You would have this H, the different legs of an H here. That being said, the enhancement is not following the H sign at all. The enhancement's actually got this very weird sort of uh, peripheral enhancement centered about the central canal almost. I don't necessarily know if it has any specificity for listeria or infectious causes or anything like that, but I just thought it was a very curious pattern of enhancement. Again, this particular case was presumed listeria, so presumed infectious, and we'll see on the next slide a quick follow-up. So here's continuation of that case as it was ongoing. So now you can see some new involvement in the distal aspect of the cord and the conus. You can have this hyperintensity in the cord. And then there's again a sort of very peripheral enhancement. And in the center of it almost looks like there's a cavity within the center of that enhancement. This is a DWI of the cord. You can see this sort of prominent DWI signal within the cord here, where there's that peripherally enhancing cavity. When you compare it to the upper aspect of the cord, I do believe that there's less DWI signal here as compared to here. I mean, it just looks a lot more bright. So there's probably true elevated DWI signal corresponding to that presumed cavity. Looking at the axial, it's really convincing now that there's a central cavity in this left aspect of the cord, and combined with the elevated DWI signal, this would be sort of a consistent with and a presumed cord pyogenic abscess in the setting of listeria transverse myelitis. And here's that area of presumed abscess formation at the follow-up. You can see the cavity is now gone, but there's a lot of cord volume loss now. And you can see here the cord volume loss. And the cord at its location where the abscess used to be appears to be tethered to the dura. So with some enhancing tissue. So presumably, as that abscess was resolving and shrinking, it formed scar tissue and got a little bit tethered to the left aspect of the dura. So case of a pretty rare case of listeria transverse myelitis and then complicated by a pyogenic cord abscess. Here's another unknown case to introduce us to the next category of diseases we'll talk about in the differential for transverse myelitis. Here you can see longitudinally extensive myelitis with hyperintensity going from cervical spine to the dorsal medulla slash area posteremia here. This is sort of dorsal medulla. This would be where area posteremia would be. There's some patchy enhancement associated with the areas of signal change, and you can see cross-sectionally there's a sort of patchy signal change, but it involves central aspect of the cord as well as majority of the cross section. Now this, just based on the findings I just described, this would actually be a pretty good look for neuromyelitis optica because you have longitudinal extensive myelitis and it goes all the way to the area posteremia, which is a pretty common and not, I shouldn't say common, but a pretty characteristic supposedly finding of neuromyelitis optica. But what's different about this case are the presence of these low signal areas lower down in the spinal canal, which are extremely crucial to detect all these little squiggly low signal areas. So the question is, what is the most important category of disease to include in the differential diagnosis? Is it infectious, demyelinating, vitamin deficiency, or vascular? And of course, due to the presence of these flow voids here, vascular is the most important category to include in the differential diagnosis. So we'll talk about spinal dural arteriovenous fistulas, which is exactly what this case is. This is an acquired disease of elderly men, so it's not something that's congenital in any way, and it's not really typically something that you see in younger people. It's in elderly and typically in male in the fifth to sixth decade of life. Clinical features of this disease actually is insidious onset of symptoms. So this is not something that presents acutely, the spinal dural or AV fistula. Insidious onset of symptoms, and it's typically due to venous hypertension and cord edema. So the cord edema that you saw in this case is due to venous hypertension from this arterial to venous fistulization. And these flow voids that you see here, these squiggly lines, typically best seen on these sagittal stir images. These squiggly lines are just those engorged veins as a result of this high flow arterial to venous connection in the spinal canal. Now, as far as imaging, it's typically the myelitis is going to be in the thoracic cord, even though the case I showed you was in the cervical cord, and the signal intensity would involve the central aspect of the cord. Unfortunately, the flow voids are really only seen 60% of the times on these traditional MRIs, and as a result, sometimes diagnosis can be missed. But having a high index of suspicion on the clinical end is pretty important. Here's another case of a spinal dural AV fistula, longitudinal extensive myelitis, this one involving the spinal cord, the thoracic spinal cord, patchy areas of enhancement in the areas of myelitis. Here, much less convincing that there are some signal voids here, potentially a little signal void there, a little signal void there. I don't think I would prospectively say there's signal voids here, although, people have different thresholds on these things, but this one would have been a pretty tricky case to say, oh, there were signal voids. But apparently this was a male, this was in the right age, and the symptom onset and character also fits. So they went on to get further imaging. Unfortunately, I don't have scrollable versions of these images saved, but as a first step, they did this high-resolution spinal MRA. As part of the spinal MRA, they did a twist sequence, which is basically they get these really fast MR images as the contrast is going through the body. So they inject contrast and then they get these really fast images so that they can see the time course of contrast through the body. Here I've shown an image when there was a big amount of contrast in the aorta. So this is the aorta. This is some of the mesenteric vessels vessels. And you can see this would be where the spinal canal is, and spinal arteries are usually puny. You're not supposed to be seeing them on these twist sequences. And you can see very beefy arterial signal already within the spinal canal. This is pretty very abnormal. And then you look at the final, the more high resolution final spinal MRA images. You can see these squiggly arterial vessels here, both anteriorly and posteriorly within the spinal canal. Again, highly suspicious for sort of arterial to venous fistulization when you see these squiggly vessels.
Now that we talked about dural AV fistulas, we'll go ahead and talk about spinal cord infarction and ischemia. Now, classically, these are due to anterior spinal artery occlusion, which would preferentially result in infarction of the anterior horns. These are the anterior horns in this simulated case, and when they're infarcted, they'll be hyperintense, and they'll give this appearance of two eyes that are called owl's eye appearance. This is a simulated case. Now, in reality, the cases of spinal cord infarct that I've seen, the imaging is quite non-specific, but the clinical presentation is quite different from everything else. I mean, these are infarctions; they're like infarcts in the brain. One minute you're okay, and the next minute you're not, and you kind of have sudden onset neurologic deficits in a very spinal sort of distribution. So the clinical clue is usually the best thing in these cases because the imaging can be quite non-specific.
Here's one such case where the imaging is quite non-specific of a very much presumed spinal cord infarction. This patient came in clinically, apparently was very good story for sudden onset neural deficits and, pretty good for an infarction. But as far as imaging, you have hyperintensity in the cord. It sort of involves a lot of the cross section of the cord, a little bit asymmetric to the left maybe. It's got some patchy enhancement associated with it, as you can see here in the post contrast, the enhancement more on the left side. So again, not at all that sort of owl's eye appearance here, but this particular case, the clinical consensus at least was that this was a spinal cord infarct. So they can be quite non-specific in their appearance. And then here's a follow-up of that case, and you can see in the regions of involvement, just profound volume loss of the cord. I mean, this cord becomes really puny. You can see cord volume loss after sort of an inflammatory process, but it's usually not quite this profound. So I think this follow-up also further supports the notion that that signal abnormality and cord lesion we saw before was due to an area of infarction more than anything else. Just like in the brain, when you infarct something, it shrinks down. Here's the cord, and it's really shrunken down. We're going to finish the lecture by talking about some spinal cord neoplasms, and I'm only going to talk about them in the setting of just contrasting between spinal cord lesions that are neoplasms versus those that are sort of inflammatory, vascular, demyelinating. Because these can really be probably their own topic of lecture. Some of the neoplasms that can occur in the spinal cord are astrocytoma, ependymoma, they're probably the most common ones, and then hemangioblastomas, metastasis, or lymphoma can also occur in the spinal cord. So here's a case of an ependymoma, and what's very different about this case compared to all the other inflammatory processes I showed you is just how irregular this thing is. This really looks like there is actually a mass here in the center of the spinal cord signal abnormality, lots of different cysts around it, and some hemorrhage around some of those cysts, the so-called cap sign with this T2 dark areas here. So this, you see something like this, having these cysts, having like a central mass-like area that you can even see on pre-contrast images. I mean, these are all T2-weighted images without contrast. You can see this one area that looks like a central mass almost. That makes you think of a neoplasm as opposed to something inflammatory. In this particular case, you can see that central area is enhancing. These cysts are pretty common. If the cyst is enhancing, it's called a tumoral cyst. If the cyst is non-enhancing, it's called a non-tumoral cyst or polar cyst. So this particular cyst, there's some enhancement surrounding it. So this is like a enhancing or tumoral cyst. So if you were to resect this thing, you probably have to take this cyst out, versus these cysts inferiorly, you might not have to necessarily take them out. And with ependymomas, having some hemorrhage and developing this cap is considered relatively common for ependymomas. So it's just a nice case of what an ependymoma can look like in the spinal cord. Here's another case. This one's not scrollable, these are static images, but I wanted to include it to show that it's not always going to be cystic. Ependymomas, they have cysts pretty frequently, but it's not universal at all here. But again, what you can see is in the center of it is just this very heterogeneous area that looks like a mass. And then surrounding this particular central mass, even on precon images, you can see a lot of edema going up and down. So again, this clues you in that there is actually you're dealing with an actual neoplasm as opposed to something inflammatory. And this was another case of an ependymoma. Now here's a case of an astrocytoma, and this is a case that's probably much more tricky to sort out whether it's a tumor versus something inflammatory, because here this is just pretty homogeneous hyperintensity throughout the cord, and then it doesn't really enhance. All of it sort of looks the same. It's not like one part looks like a mass and the rest of it is not mass-like, etc. However, one thing is that it's really got this shouldered appearance. It expands the cord greatly, but the upper margin of it, where it expands, really abruptly ends, and that would be pretty rare for your inflammatory processes. The inflammatory processes tend to be much more diffuse and sort of gradually taper to a normal cord. Like this bottom part of this looks pretty gradual tapering, with this top part not at all. It's like a nice big shoulder of swollen cord versus not swollen cord. So this case it was a case of an astrocytoma, and I think probably just because of this top appearance, you should be able to tell that this you're also dealing with potentially a neoplasm as opposed to actual inflammatory process. On the actual images, you can also sort of say that it almost perhaps a little bit more that there's perhaps something encapsulated here as opposed to just a diffuse inflammatory ill-defined process. Here's another case of an astrocytoma. Again, this one is not scrollable, but I just wanted to include it to show some heterogeneity in what these tumors can look like. Here's another astrocytoma, and this looks a lot more like that ependymoma that I showed first. Again, you have a central mass here. You can see it even on pre-contrast images that's sort of enhancing. You have all these cysts, some of them enhancing, some of them like this top one not enhancing. So you have both tumoral and non-tumoral cysts. So again, even astrocytomas can have those sort of a lot of the features you can see in ependymomas. And I'd like to show this case just because to show you can't quite necessarily tell but if something's an astrocytoma, whether something's an ependymoma, even though people like to talk about distinguishing features, at the end of the day, there's a lot of overlap between them. Even this astrocytoma has some hemorrhage within it, which is considered to be much more likely for an ependymoma as compared to an astrocytoma. So there's a lot of heterogeneity between the two and overlap between the two. So I'll include a cavernoma in our discussion just because they have a relatively unique appearance that's good for everyone to be aware of. So cavernomas in the spinal cord, just like in the brain, have this popcorn appearance. You can see T2 bright lesion here has a lobulated contours and some internal sort of septations almost that are T2 dark, giving it that popcorn appearance. There's typically going to be a cap of T2 hypointensity surrounding the cavernoma, which would be the sort of a hemosiderin cap. And then that T2 darkness will go up and down, a lot of it within the central canal. And when it goes up and down in the central canal, it's called hematomyelia. Here you can see on the actual images, here's that central part with the T2 hyperintensity hemosiderin cap. And as you go down, for instance, you can see a lot of that T2 darkness within the central canal. And then as you go up, again, a lot of that darkness within the central canal. So probably these are the sequelae of prior episodes of hemorrhage and some of that blood getting into the central canal and then resolving as hemosiderin. Now I've put this in quotation marks just because we typically see an image like this and we consider it pathognomonic of a cavernoma. It probably is not quite as pathognomonic as we think because this particular case had surgery, had this thing excised, and it under histopathologic assessment, the diagnosis was a hemangioma. And cavernomas and hemangiomas are pretty different. Cavernoma is a vascular malformation, while hemangioma is a true benign neoplasm. But regardless, it is a sort of a benign vascular process, and I think that's the important thing. if you were to see something like this, your interpretation should still, even seeing something like this where it's not a cavernoma, your interpretation should still be that this is most consistent with a cavernoma, just because the imaging is so pathognomonic. Regardless, even if it turns out to be something else, it's most likely going to be something vascular and something that's benign. And so any decision to intervene on something like this should be based on symptoms and location, as opposed to somebody thinking this is something malignant that's going to be bad. So we went over a lot of etiologies of spinal cord lesions. So we'll do a quick recap and a very basic approach. This basic approach doesn't include everything that you can see in the spinal cord, but I think it's a good starting point as you're learning out. So the first question I always ask when I'm encountering a spinal cord lesion is, do I favor this to be a neoplasm? And you favor it to be a neoplasm when you clearly see something central that looks like a mass. And I found especially the non-contrast images to be very helpful for this determination, just because once you give contrast, even inflammatory processes can have patchy enhancement. So, but on the non-contrast, if you have a central area that looks like it could be a mass, that favors neoplasm. Or if you have something, you don't have like a central prominent mass-like area, if you have like asymmetry in the swelling, or the swelling seems to suddenly turn off at some point, that probably should favor a neoplasm. And then obviously remember this relatively pathognomonic appearance of what a cavernoma should look like. Then I ask myself a question, is this by imaging a partial transverse myelitis pattern? And partial transverse myelitis being a clinical syndrome that's unilateral, but imaging correlate of it would be just a lesion involving one side of the spinal cord. And if you see a lesion like that, as you recall, you have to remember that majority of these end up being MS. So, and to diagnose MS, you need brain MRI. So if you see a lesion like this, always recommend the brain MRI, because more likely than not, it'll be MS. With a lot of some other times it'll be idiopathic, obviously, but MS, 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 and recommend brain MRI. Then I ask if I'm dealing with a transverse myelitis pattern, and if the transverse myelitis obviously being, you have both sides of the cord involved, either by symptoms or by imaging appearance. Now, once I encounter this transverse myelitis pattern for myself, then I do a pattern-based approach for the not misdiagnosis, because it becomes a differential at this point when you're dealing with transverse myelitis type of patterns. But there are certain features that you should add that are not misdiagnosis. So among those are spondylitic forms that mimic a transverse myelitis pattern. So spondylitic forms, so anytime you see, cord compression and you see some enhancement, think of whether that could be due to something spondylitic. Now, it could also be just very short segment T2 hyperintensity, which is more common, but as you recall, we showed a lot of the cases of this enhancing spondylitic pattern as well. So basically, anytime you see cord compression and any lesion that's next to the cord compression, some spondylitic etiology is to be included in your differential. Then, if there's a prominent posterior column involvement, you would think subacute combined degeneration, and it has a differential, but the most common of those is vitamin B12 deficiencies. Very important to mention this because it is so easily reversible with vitamin B12 supplementation. So, definitely a not misdiagnosis. Also very important is to look for flow voids, because if you see flow voids, absolutely have to recommend the presence, suggest the presence of an arteriovenous fistula, and that obviously very different management approach compared to other inflammatory causes of transverse myelitis. And as you saw in the case I showed of this AV fistula, the just everything else besides the flow voids looked just like something like NMO, for instance, but the flow voids really sort of turns you down the vascular pathway. And the flow voids, remember, they don't necessarily are going to be right next to the hyperintensity. Here, the hyperintensity is up in the cervical spine, but the flow voids are in the thoracic spine. So keep that in mind.
Then, if you see anterior horn involvement, you should think of an infarction, or as shown here, this owl's eyes appearing. Although, as we discussed, the imaging in infarcts can be quite nonspecific, and it's really that clinical history that's the most important for infarcts.
Finally, if you see something that's very central predominant, you have that H sign where you have the central gray matter of the cord being affected, or you have prominent involvement of the conus. Good to include MOGAD in the differential just because those are considered to be sort of relatively characteristic in MOGAD. That being said, sort of MOGAD and NMO you can always include in the diagnosis of transverse myelitis. Especially NMO should really always be included in transverse myelitis sort of differential diagnosis, unless you have some of these other more characteristic features in your imaging findings. And as a final reminder, there's a highly complementary role of brain MRI for pretty much all of these spinal cord lesions. You can never go wrong by recommending a brain MRI to also be performed for further characterization of some of these lesions. If a lesion, for instance, looks tumor-like, but you get a brain MRI and there's also additional lesions in the brain, then you have to really step back and ask yourself, could I be dealing with something inflammatory? Because most often the answer is yes. And as you saw, the very first case that I showed in the lecture, of course, you can sometimes, by obtaining a brain MRI, give the fixed final diagnosis for some of these spinal cord lesions. So keep brain MRI also in the back of your mind. Thank you.